Hello, good morning, and welcome as people join us. We are grateful and happy that you are here to join us for understanding and implementing indicated prevention strategies. We're going to give it just a minute while the rest of our colleagues join us. So we are excited to have you here. So let's just wait 1 minute.
Good morning.
Good morning. Wonderful. Thank you for being here this morning.
And thank you. I appreciate these strategies.
I'm so glad. Well, it's going to be fun today. So with that, we have a few more people joining, so we just want to make sure they all get in before we take off here this morning. Wonderful, wonderful. Again, thanks all for joining us this morning for understanding and implementing indicated prevention strategies. My name is Erin Ficker. I'm with the Great Lakes PTTC, and we are really glad to have you here in this webinar this morning. And we will get started in just 1 more minute as we are waiting for our colleagues to join us. All of y'all, we're very happy to have you here. Oh, good morning from West Virginia. Oh, wonderful, wonderful. Yeah, feel free to write your name, not your name, because we can see your name, where you're from, what your role in prevention is as you come in. We love to see where people are from. It's so fun. So if you want to go ahead and do that as we wait for just 1 minute, we have lots of people joining us, which is wonderful. Oh, Connecticut, Moses Lake, Michigan, Ohio, Michigan, Ohio, California. It is early for you. That is commitment. Portland, Maine, go Bucks. Columbus, Ohio. Oh my goodness. I saw Louisiana. Chicago, I'm right there with you. Wonderful. Okay. Oh my gosh. So like all around the country, Tampa, Florida, Louisiana, Kentucky, Ohio. Oh my goodness. You guys have really come from all over, and we are so, so happy to have you here today. So I'm going to go ahead and get us started. Again, my name is Erin Ficker. I'm with the Great Lakes PTTC, and we are delighted here today to, excuse me, to have Ashley Bodiford here with us for understanding and implementing indicated prevention strategies. So let's get started. Welcome all. So as we learn about, so I asked, and you guys are already doing it, so we're happy to see you guys all sharing your name and where you're from, organization. So thank you so much for that. So today's webinar is brought to you by the Great Lakes PTTC and SAMHSA. We're funded through the following contract numbers. So we're happy to be here. And just as a reminder, the views and opinions of the speakers do not reflect the official opinions of the Department of Health and Human Services or SAMHSA. No official support or endorsement from DHHS, SAMHSA, or the opinions described in this presentation is indicated or is intended or should be inferred. So we are not, so we are not reflecting the official position of SAMHSA in this. So at the PTTC, we use affirming language. We believe that language matters, and we use people first language in our work and ask that you do the same. Just so a few housekeeping items today. If you have any technical issues, Shannon Cassidy is here to help you, and you can direct chat her if you need some assistance. If captions or a live transcript would be helpful, please use your Zoom toolbar near the bottom of your screen to enable that by going to more screens, select captions, show captions. So it's a little hard to find, but you'll get there, I promise. A few more housekeeping items. Just if you have questions for the speaker, put them in the chat. We will do our best to make sure they all get addressed. You'll be directed to a link for a short survey after the session, and we absolutely super appreciate it if you could fill that out. It only takes about 3 minutes, and it does help us continue to plan for and improve our services. Certificates of attendance will be provided via email to everyone who attends the full session. If you can take up it can take us up to 3 weeks to get you those certificates. So if you can just be patient, we promise we will get them to you. And without further ado, I would like to turn this over to Ashley Bodiford, who is joining us from South Carolina.
Yeah.
And has power this morning, so we're glad for that.
Me too.
Enduring a tropical storm and still committed to being here with us. So I'm going to turn over to Ashley. Thank you so much for being here. And if you want to just start us with our objectives.
Perfect. Thanks so much, Erin. Good morning, everybody. I hope you are all doing well. Like Erin mentioned, my name is Ashley Bodiford, and I am coming to you from South Carolina. It's a beautiful morning in South Carolina. We would not know that a tropical storm rolled through here last night, at least not where I am. I think some of my friends in the lower part of the country and at our beautiful coastlines probably are experiencing a little more of that. Probably like our friends in the Floridas and the other southern states. So I do hope everyone is safe and well and all doing okay and didn't endure too much. But I am so happy to be here with you this morning for our third and final series, or webinar in our 3-part series, as we've worked through understanding the spectrum of mental, emotional, and behavioral interventions, and then really breaking down and understanding the 3 different types of prevention: universal, selective, and then today with indicated. So I'm hopeful that some of you were able to join those previous sessions and are here for this final one. And with that, we are going to just kind of jump right in and get started. So for today, we really are going to focus just how we've done the past 2, is really understanding what indicated prevention entails. We're going to focus and spend some time really describing what indicated prevention means and how we can be the most familiar and comfortable explaining that to the people that we work with, partners, funders, leadership at maybe an agency, maybe depending on how you're kind of structured. And then kind of finally, as we wrap things up, we want to make sure that everyone walks away understanding how to effectively implement indicated prevention strategies while also maintaining that fidelity. You know, that's always kind of a buzzword and something we really want to pay special attention to in our work, that we're doing things as it was intended to be done, not causing any more harm or not intending to cause harm, or, you know, doing something that wasn't intended to be done that specific way for that specific population group, specific program, etc. So that's really our plan for today. It's so great to see so many of you from all over the place. Like Erin was mentioning, we've got a nice representation of lots of different states, and so that's always really fun. I saw some Chicago's. I know Erin's in Chicago. I was in Chicago last weekend, and had the best time. It was so beautiful. I'm already ready to go back. Chicago is definitely one of my favorite cities, and so I had to say goodbye to a friend who moved to Chicago, so I'm sad for that, but happy that she picked Chicago because I'm happy to go see her. And so with that, you know, I wanted to just let you know that this is an informal setup. So as you have questions, please put them in the chat, like Erin mentioned, and we're going to monitor and do our best to answer them as in real time as we can. We also have worked in time at the end to also take questions, but certainly don't sit on a question or hold it till the end. If you have something on your mind, certainly go ahead and plop it into the chat, and we will kind of pay special attention to that in real time. So let's go ahead and jump right into our conversation, and really focusing here on just a little gentle reminder about this image. So for the past 2 sessions, if you've been able to join, you likely have seen this, or even beforehand, you probably have seen this image. And this is really a great opportunity. It's given us some time to look at and pay special attention to the updates that the spectrum of mental, emotional, and behavioral interventions that has kind of shifted. And so for some of us, this may look familiar to what we used to call the continuum of care. And really, for the most part, there's not a ton of changes from that. I still very much get tripped up and will continue to probably call this the continuum forever and ever. But I'm trying my very best to adapt to the new name. But what's most important here just to remind us of the conversations that we've had about this before we jump right back into the indicated conversation, are just a couple things. And so what we're first noticing here, again, just as a reminder, is that the title has shifted, and with some other things, but really what's most important is not so much knowing that the title has changed for this model, but really more about understanding the changes that were made and how we apply them as prevention professionals and practitioners. And so when we look quickly at this this image, this kind of half moon is what I kind of like to refer to it as, there's going to be some changes, but two really big major changes. The first is found in promotion, that if you've seen this before, promotion just used to be one little kind of chunk. Now it's divided into 3 segments. And this has really been done because of the need to know and understand that we need an increase in promotion services. And with that increase, they really need to be focusing on different levels of promotion of health and well-being. And so that's why you now see those 3 chunks with individual and family, community, and societal. You'll see that community is the largest of the 3, individual and family comes next, and then societal is the smallest. Really, though, the importance there is just understanding that promotion is happening in 3 different contexts. And so it's important that we know that so that we're implementing appropriately for the appropriate audience in the correct context as we work through this information. We find that information after we conduct things like needs assessment, some capacity assessment, resource assessment. It all kind of starts to make sense there and then. So I don't want to digress too far into that because that may be a different topic, but just to give us a reminder about why we've seen some changes. The next big change that you'll see just as you follow along that this model is that prevention also is in 3 sections. That's not specifically different, but what you are now seeing different is the segment sizes. So you're still seeing universal, selective, and indicated prevention, which that's been like that for quite some time. But now what we're seeing is the 3 sections being different sizes. And so we're seeing universal is the largest, which kind of makes sense, right? Because as a reminder, universal prevention interventions are the ones that are really focusing on the general public or population subgroup that have not been identified on the basis of any type of risk. So examples might be education for physicians on prescription drug misuse, or perhaps a skill-based educational curriculum for all middle school students. That might be something that falls in line there. So it's large, it takes kind of a focal point. A lot of conversations that we've had over the past couple webinars, people have been pretty vocal that universal kind of takes the lead, as how I'd like to call that. Not so much priority, but takes the lead on the amount of time that they spend implementing prevention strategies. And we'll talk a little bit about why that is as we kind of move throughout. The next segment is selective. That was our presentation, our webinar last week that we had some really great conversation with. But just as reminders, selective prevention are those interventions that are really focusing on individuals or subgroups of a defined population, as a reminder, whose risk of developing behavioral health disorders is significantly higher than average, but not so much by their own choice or doing. So some examples here might be, for strategy, might be prevention education for individuals whose parents are diagnosed with a substance use disorder. That might be a quick example. So that might be something we could do for that specific subgroup. And then the last little chunk there you see is indicated, which we're going to talk about today. So just to kind of start foreshadowing this, indicated prevention interventions are really those strategies that are focusing on high-risk individuals who are identified as having minimal but detectable signs or symptoms that are really foreshadowing behavioral health disorders, but this is probably the biggest important piece here, but have not met a diagnostic level at this current time. So I'm not going to get so much into examples here just yet, because that's really what today is all about. So we'll dissect that a little bit more as we kind of move throughout. But a good reminder that with indicated, we're still working in prevention. So sometimes we may get a little bit of questions about that. And so I want to make sure we talk through that and are comfortable as we kind of move throughout. And then as we keep moving, we always want to make sure we are competent and comfortable talking about the remainder of this model. Oftentimes we may hear, well, I stop at prevention because that's my job and I don't do anything else. And while that may be true in terms of job, it's still important and critical for us as prevention practitioners to be well-versed and able to communicate about the full spectrum. And so then we move to treatment, where you have two segments that are really very much the same in size. For the most part, I don't really tend to see much of a different segment size here, with case identification and then actual treatment of the disorder that the individual has been diagnosed with. And then we push and go into maintenance, where we're talking about long-term treatment. So somebody may be really in treatment for a long-term type plan based on their diagnosis, maybe based on some co-occurring disorder, lots of different reasons. And then aftercare. So really focusing on that recovery support, recovery integration into that person's plan of care, essentially. And then all along the bottom, we always and have for quite some time and continue to see promotion. And so this is a great reminder that promotion really isn't supposed to just be one section. It certainly is its own, but as prevention professionals and anyone working in behavioral health, it's really important that we're integrating promotion into all of these segments. So making sure that overarching themes of health, well-being, are all being integrated into the work that we're doing, into the strategies that we're doing. So this is a great reminder that that's supposed to happen and should kind of be monitored and integrated as such. And so it's really, really important to be mindful of that as well. All right. Oh, I just saw in the chat someone is in Greenville. You're so close to me. You're like 2 hours away. We will have to, I'd love to connect and help out any way that I can, and welcome to prevention. All right, so just was peeking at the chat real quick. So let's pump to the next slide here, which is just showing us just prevention. So this is kind of where we spend a lot of our time, right? A lot of our focus, a lot of our energy, a lot of everything, obviously, as we're working in prevention. And so this is just that nice, gentle reminder that shows the three different segments that we talked about, the different segment sizes. Again, as a reminder, those segment sizes, the larger ones, are really reflecting where more mental, emotional, and behavioral interventions and strategies really need to focus when developing and implementing that comprehensive community prevention plan to prevent any type of current, that's more of a manage maybe, but prevent any type of future mental, emotional, behavioral situations or issues kind of from arising or taking place. And so what's important to remember, so I like to say that very carefully, because people can misinterpret certainly what that means and say, well, universal is the largest segment, so I should spend all my time there. That's definitely not what I'm saying or what this image means. Really what that means is that more is going to focus on universal for a couple of reasons, right? One, universal is such a broad category. And so we can reach such a large group with universal prevention strategies because everybody all gets the same thing. So a whole school could get life skills education curriculum. A whole community could get a comprehensive media campaign. A whole community could get policy change, or a whole college, let's say it that way. A whole university could get a policy change around access to alcohol and substance use, things like that. So that's why universal tends to be largest, just because the focus of the population is much larger than that of selective, because that's a smaller subgroup, and indicated because that's a smaller subgroup also, because they're specifically placed into those categories based on certain things. Now, also a good reminder, it does not mean that individuals that are falling within selective and indicated don't also live in universal. So we have to be mindful about that as well, because, for example, let's say you are in a community that has decided that they'd like some formal curriculum education in a school setting. And so you're going into all the 7th grade middle school and implementing something skill-based. It doesn't mean that individuals in your group are not also falling in the selective and indicated category, right? So you could have 5 of your 7th grade students that are all getting life skills who are living with parents that have a substance use disorder, meaning that they are also in a selective category. You could also have individuals who are engaging in that risky behavior but aren't in a place of diagnosis in universal. It doesn't harm them to receive that universal prevention strategy, but what we know is it's not enough, right? So those individuals have to really be identified, and we're going to talk a little bit about how we do that in just a second, but really need to be identified and opportunities given so that they have the ability to receive some different type of prevention strategy based on their participation and identification in that subgroup. So just good reminders there about what that means. Certainly doesn't mean that. And so as we kind of wrap the section chat, it's important as we just kind of remind ourselves that we really do need interventions in all categories, all 3, 6, 7, 8, 9, 10, all 10 segments, right? So across the entire spectrum. Also, every intervention should incorporate promotion within it. We just need a greater proportion, as you can see here, to focus on promotion and prevention. And so what we do in our work is we want to prevent any type of MEB problem from happening, from occurring, while also being mindful that it's hard, right? It's hard to do that. So we have to be well versed in how we can make sure people that are moving beyond that place of indicated prevention get the resources, get the help, get the assistance that they need so that they can enter into a place of healthy living through different types of modalities. It's just not for us to implement those modalities. It is important for us, though, to know how to talk about it, to make the appropriate referral and connection. So it's just good reminders that while your work may stop at that green little line, your understanding, knowledge, comfort level doesn't. So making sure we spend enough time really working through the understanding of this spectrum is really important for continued success and continued community health and well-being. All right. So let's kind of talk a little bit now just about understanding indicated prevention. So we've talked a lot about universal, we've talked a lot about selective, and now we want to make sure that indicated has a turn to get that same type of attention as we really kind of break down what this looks like and what this means. So when we talk about defining indicated prevention, we talked a little bit about this just a second ago, but we're going to kind of expand obviously further because that's the point of today's webinar. So what we're really speaking about here as we define indicated prevention is knowing that this is examples of indicated prevention strategies that are focusing on individuals who are exhibiting early signs of substance misuse, other behavioral problems, and then provide them with specific programming that match their place in the indicated prevention group. And so what we really are talking about like this could be something around in the field of substance misuse, some type of indicated prevention strategy. For a quick example, just to kind of get your brains thinking on this wavelength, might be a substance misuse program for high school students who are experiencing a number of problems that might include a range of things. So it doesn't have to just be substance misuse. It could also include truancy, poor academic performance, maybe some type of depression, anxiety, suicidal ideation, and also substance misuse, early signs of substance misuse. So oftentimes that is what happens. Oftentimes it's not just one thing that deems that individual to be in the indicated prevention subgroup. It can be a multiple context of things. It's important to talk about this because it really lends itself to why we should have strong partnerships with other human services or behavioral health providers, because oftentimes we are not in the world of handling all the things, right? And so, for example, how would we maybe know that someone or a student, I guess I should say that we kind of identified that group all the way. How do we know that they may be having some truancy issues or, having poor academic performance? For the most part, at least in my situation, I'm not really going to know that off the cuff. So I'm going to have a pretty strong partnership with my school system so that we can have some conversations around rates. What's the percentage of rates of truancy in your school or academic failure? What's the percentage of students who are engaged in mental health services? And again, those conversations take time. By no means am I saying we can just walk in on a Monday and ask to meet with all the key leadership at the school and get all that information. There certainly are some processes that would need to happen before we get that information. But oftentimes the schools maybe don't know that we exist. That happens quite a bit. I don't know if any of you have experience with that, but certainly something that even at my local agency is working on. We've been in existence for umpteen years, and we still hear that people are like, I didn't even know about you guys. And so it reminds us that, you know, we have to do a better job of making people aware of who we are and the services that we provide. And we do that by having these conversations. So kind of circling back on what I was talking about just a few minutes ago, the way in which that we can learn and understand kind of what's happening with our populations is by asking and having conversations and being very careful to not make any type of assumption. There's so much danger in making assumptions. We can really harm our community, harm our subgroups, create distrust, and the level of time and resources and energy it takes to resume that trust is quite consuming. So it's helpful to be careful and cautious on the front end and really just engage in those conversations, to communicate with those partners about who we are, kind of what we do, and what we'd like to know more about. So those are just some examples of how we maybe could get that information to engage in those conversations with those partner groups, so we can learn a little bit about more like why things are happening. As prevention providers, we often can do a very great job of identifying the what. And then it's important to work with our partners to learn the why. So we may have some school reports that tell us that 20% of students are academically failing, but then we're missing the understanding portion as to why that's happening. So engaging with schools, engaging with parents about what we can do and provide services for can help us, one, understand a little bit better about why things are happening, what's happening, but it also can lend itself to opportunities to help and identify ways in which help really needs to happen, not by making assumptions and thinking that we just know, right? So that's just a nice identifying way to think about indicated prevention and what that looks like, kind of who we're focusing on, what may be contributing, and a great reminder to always think bigger than just substance misuse. Again, that's our wheelhouse, so it's always at the forefront. But the reality that there's probably some cross factors is very, very likely, especially among adolescents. And so having good, strong partnerships with the people that can provide services for all those things, give information about that specific information can really just help us be the most effective in our work, do the most best we can do for the individuals that need those services, and really hope to work to see some healthy, successful outcomes. So talking a little bit more about this indicated prevention, it's really focused and helped and really designed to prevent the onset of substance misuse in individuals who are not meeting criteria on that DSM-5 for substance use disorder. We shorthand that to SUD. If you've not heard that, that's what that's referring to. So we understand and identify this by seeing and knowing that individuals are exhibiting substance misuse like behavior, but again, at a subclinical level. So no diagnosis, no indication of diagnosis, and a diagnosis has not been made. It's just kind of that, some people may refer to it as like early initiation, kind of early onset of use, still some opportunities to create some behavior change through some prevention work, indicated prevention work to be specific, before we get to a different place where diagnosis and more treatment type services are needed, obviously. And so when we think about indicated prevention, really we are talking about approaches that are used for individuals who are exhibiting those risk factors that are increasing their chances of developing a substance use disorder. So we really, when we think about this, it's really, again, going back to understanding what's going on, what's really happening, why is it happening, and not just making any type of assumption based on what we think we know. That can be really, really dangerous, and oftentimes can really end in poor outcomes, unfortunately. And so most of the time this happens with unintentional issue, like none of us are out seeking trying to get to bad outcomes or trying to do more harm, but sometimes we can get comfortable and complacent in making assumptions about a lot of different things. And we'll talk about that in just a second as we explore a little bit about risk and protective factors when it connects to indicated prevention. But reminding ourselves that it's our responsibility to know exactly what's going on in that community, or to the best that we can. Certainly I could write a book on all the barriers that we all experience when we're just trying to figure out what's going on. You know, people don't want to talk to us, they don't want to give us data, they don't want to let us into a school system to collect the data for maybe fear of what may come out. There's still so much stigma associated with substance use, substance misuse. And so it's hard, right? It's not easy to get this information, but it's important that we get it, because we would like, we want to make sure that that we understand what exactly is happening. And so we can make the most best program plan, best comprehensive plan for our communities that does not create any type of harm, and we're not missing the mark, right? So if we have a situation and we're totally addressing the wrong situation, it's just to be mindful about that. I think I just saw a question pop up. So yes, so does this category include children who are born addicted? Great question. And so a good reminder is we want to be mindful about what this can look like. And so when we think about babies who really aren't born in an addiction, right? Because they're not engaging, obviously, in that type of behavior. However, we have lots of babies who may be born dependent, right, on some type of substance, and what that can look like. And so thinking about indicated prevention, it could certainly include individuals who are born with some type of dependency, but it might be difficult to engage, obviously, at such a young age. However, it could be more impactful in later life. And so initially, what this could look like, and this is where we want to be careful about assumptions, because if a mother, Richard, definitely hard to collect that data. If a mother may have been engaging in substance misuse during pregnancy, in definition terms, that would really be more of a selective type of audience, right? Because that individual, that child, was perhaps born with some type of dependency, could still be living with a parent with a substance use disorder. Again, I'm saying could very, very cautiously, because that's really tinkering on assumption. And what people identify as substance use disorder, it can be very different for a lot of different people. So it could be more that individual may just have some experience with substance use. It could be that may still be happening, may not. Again, careful with assumptions there. But I would more so lean to, at some point, that could be more of a selective type of subgroup first. We know that there's lots of correlation, though, between selective subgroups and how it can move into indicated, just because of availability, genetic predisposition, things like that we are definitely going to talk about actually in the next 2 slides when it comes to that type of thing. So great question. I certainly, I think it could connect. So you're asking about, kids who have obviously grown up and they're now older and not still babies. I think it depends on what's going on in that young person's life now, right? So they're going to have some genetic predisposition just because of substance misuse being present. But we would have to really dissect and understand what's going on in that young person's life now, as you're kind of referencing a 9 to a 12-year-old, for example, or older. What's really going on, right? So we always be mindful about, they could be struggling with substance misuse, they may not be. They could be engaged in risky behavior, they may not be. And so I think we know that there may be some additional opportunities here, because that individual just is going to have the genetic predisposition, that biological disposition, but really doing our work to understand what's really going on right now. So that's a great question. All right, so when we talk about this defining indicated prevention continued, so we've talked a little bit about these approaches are used for individuals who are exhibiting those risk factors that increase those chances for developing that substance use disorder. So again, could happen here, and it would really require some individual assessment, some understanding, some partnership work, and things of that nature. All right. So when we are focusing on indicated prevention programs, we are really spending a good bit of time understanding what needs to happen. And so first and foremost, we're first looking at not only the reduction in first-time substance misuse, but we're also looking at how do we reduce the length in time of the signs continuing. So how do we lessen that substance misuse kind of experimentation is sometimes how we may think about it that way. How do we reduce that length of time? Matched with how do we delay the onset of substance misuse? How can we push that a little bit further and a little bit further back? Not saying that by a certain age we're safe, right? We know this, but what we also know is the older that individuals wait to misuse or engage in substance use, the less likely they are to face substance use disorder in later life, right? So a 12-year-old is going to be at a much greater risk for developing a substance use disorder if they start to engage in that behavior at around the 12 to 13-year-old mark or younger versus an 18-year-old. Again, the 18-year-old isn't 100% protected, right? We know that, but there is a less chance. Same for like a 25-year-old. Again, no magic number protects us to any of those types of things. But what we know is if we can delay onset, we can also have a greater chance in delaying any type of substance use disorder that's present in later life. So really good things to remember as well. It also can help us to reduce the severity of substance misuse. So if we are able to see the delays and the reductions, then we also can maybe minimize how severe a person is misusing those substances based on their participation in indicated prevention programs. So some things to kind of think about here is really that aim. The aim is really not, again, not only that reduction in just the first time. Like, of course we want to see that, right? But that's not the only thing we're focusing on. We really want to see these reductions take place. And so when we think about like, well, what can we do? One quick example to think about here is individuals can be referred to indicated prevention programs by multiple people. It could be parents, it could be a teacher, could be a school counselor, a school nurse, maybe a youth worker, a court system, friends, or even youth can voluntarily participate in indicated prevention programs. I'm sure some of you may be like, oh yeah, right. I'm not saying that that's the prominent type of participation in indicated prevention programs, but it can happen. And the way in which it can happen is by people being aware of what the program can look like and offer. One of my favorite kind of sayings when we teach other programs is people don't know what they don't know. And so again, it's very easy for us to be thinking and saying like, well, we have these programs, I'm not really sure why nobody, uses them or engages in them. But if nobody knows about them or knows what the process is or what they do and don't have to do, I mean, the likelihood that they're going to reach out to us is probably pretty slim. And that is the same for our partners too. So for example, if a school system doesn't know that some of us may offer indicated prevention programs, they don't know to connect, they don't know to make a referral, they don't know to make that exchange between the individual who needs the services to the service provider. And so it's a great reminder that we have a lot to do, right, guys? We have a lot to do. We have to do the services. We have to understand our communities. We have to, promote our services. It's a lot, but the reality is if we don't do it, we're never going to reach the population that desperately needs us. So making sure that we are spending the appropriate amount of time communicating effectively what we offer, how we offer it, how to go about it, what it's going to entail, what you do, what you don't do is important. Because one, people don't know about it, or two, they learn about it through hearsay and they make their own kind of representation. So it could, it can turn into like, well, I know about this program, but ABC has to happen when really only A has to happen. And they've kind of created B and C, and it really isn't true. So just a good way to think about this. Lots of different ways that we can go about communicating about indicated prevention programs, what they offer, what they look like, what they entail, and how to access those services, and really what the goal is. That's also a great reminder that it's helpful to let people know what we're trying to achieve. It isn't just refer the kids who are making bad choices and let's check that box and get them through a program. That's not at all what indicated prevention really is. It's really about these three things that we're looking at in terms of reduction of length of time, delaying that onset of substance misuse, and doing our very best to try to reduce any type of severity and long-term substance misuse for people that are going through some of these types of things. Right. Speaking, great. So again, great just reminder on focusing on indicated prevention programs, what the goal is, how we do it, what we're doing, what we're really trying to achieve. And taking stock of what's working and what's not working here is also really important. So we're going to talk a little bit more towards the end of this webinar about fidelity, but thinking now, also doing our own kind of I'll call it, program assessment, honestly, to ensure that we're seeing the outcomes that we were hoping to see. And if we're not, what do we need to do to make some mid-course corrections, make some adaptations and things like that? So kind of as we think through this, we also want to make sure that we're kind of working that in as well. But I promise we'll kind of get to that more on the fidelity kind of conversation in just a little bit. All right, here we go. So then we kind of get to this place of, well, what do we even do when, here you are talking about indicated prevention programs, and like, what does that even mean, right? So what's important here to remember is that indicated prevention programs are really, really focusing less emphasis on assessing and addressing environmental influences. And that's different. That sometimes is a different kind of thought for prevention professionals, because we often spend a lot of time figuring out, like, how do we influence the environment? How do we change communities? How do we change the environment where people are living, growing, raising families, to change it to be the most healthy environment where there's low access, low availability, economic rich, so many programs and resources that people don't have the ability to misuse substances because they're engaged in so many different things, right? Like, we spend a lot of time there, which is great. We need to. Those are things that we can broadly reach. We can have great impact. We can have great process. We can reach hundreds of people through those types of strategies and work. And it's important, and we should be. However, indicated prevention is not about changing the environment. It's much more about individual. And so this can be difficult because it takes a long time, right? One-on-one individual work is hard. It takes time. It takes participation, which can also be difficult, right? If you are working with a group of kids who have no desire to talk to you, to be active in your program, to do the things that you have asked them to do, it's tough. It is tough work. But it's important work, and it shouldn't be left out of the scope of prevention services just because it's tough. And so some of the things that we look at when we are focusing on indicated prevention programs are programs that are really around addressing risk factors associated with that individual. And so we might think about things like conduct disorder, some maybe young people who are, or anybody really, not just young people, individuals who are struggling with following rules and regulations and find themselves constantly doing things that they're not supposed to be doing, right? So kind of conduct disorder. We also may see some risk factor connected to alienation from parents. This is hard, right? When we're working with young people, especially, but anyone who may have experience with parental alienation, which kind of lends itself to like low parental monitoring, maybe norms and kind of what's allowed and unallowed, and working through some of those barriers can be really, really difficult as a prevention professional. It may even look like school alienation. So perhaps we have, that one would obviously be more for young people, but kids who aren't going to school, then that's going to connect to the things we talked about a few slides ago, like truancy, poor academic performance, some other things that are not bigger than, but that are at the same caliber of substance misuse, right? Like, you've got 6 problems to address and you're only one person. What do you do? What do you do in this situation? Does one problem, lend itself to be more important than another? Not really. I think depending on severity and looking at some things, all the problems are important. And you're kind of one piece of that big, myriad there. So you're here to focus on one thing, but you identify 6 things that come up. It's difficult, right? And then maybe another example might be alienation from positive peer groups. This can also be tough too. So if there are opportunities to engage in positive peer groups and we are in 0 of them, it's difficult to change the perception of what is real for that individual. And so just being mindful about that is really, really critical, kind of what we're dealing with. This also lends itself to why there is such merit and such importance in assessment and really understanding what is going on, but why. And we can't create any type of assumption because we don't know. If we don't have the data, we don't know. We can get different types of data, certainly, but making assumptions is just really unsafe and really shouldn't be doing that. And so when we think about this, we really want to make sure that these are considered when you're working on indicated prevention, strategy identification, strategy implementation, identifying a focus group, but also making sure you have the appropriate partners at your table. Because oftentimes, like we were saying, oftentimes there's a little bit of crossover in the risk factor or the contributing factors that make it really difficult to do this in isolation. So just to kind of get us thinking in that capacity. All right. Let's kind of look next here at what this may look like. Okay. All right. So when we are thinking, I've mentioned risk and protective factors a couple times. So now we're going to really talk about what this means. This is probably one of my favorite categories to talk about. Some people may not specifically love a risk and protective factor, but I think the importance of understanding risk and protective factors in your communities is probably, it's critical to really understand why. And what I mean by that is it can be easy for us to get, a packaged data report that says your state ranks this, and this when it comes to these 3 indicators, right? What a packaged report may not tell you is why. What a packaged report may also not tell you is the differences among your sub-communities. So all of us have, a state, then we have counties, then we have communities within the county, and then we have sub-communities, and it can really build, right? And so some important notes to think about is being so extremely careful to not create assumptions. I know I've mentioned this and you've probably heard it, but it warrants just reminding that it's so important that we are not making assumptions. Because what we can do is we see something that happens in community A and we think, oh, well, community B is probably experiencing the same thing. So we're just going to replicate all the things we're doing in community A to community B and kind of keep it moving. And let's go see what's happening in C now, because we're on the right path. We're moving full steam ahead. And then, 3 to 6 months go by and community A is doing great. Community B is not doing great. And we're thinking, why? Why? What's going on? We've identified problems. We've selected indicated prevention strategies, but we're not seeing near the positive outcomes that we are in community A. What often happens is the whys in the community are different. So we may have comprehensive across the bar youth substance misuse as a problem, right? But community A's reason is because of accessibility, and community B's reason is maybe about parental monitoring, right? Or community norm. It could be so many different things. Truly, we could spend a long time doing the whys, right? Those strategies look different. When you're talking about retail accessibility and parental monitoring, moving to the same type of prevention strategy for those reasons are not going to produce successful outcomes because the strategies are different for that specific reason. And so that's why it's so critically important that we are doing our due diligence in assessing and understanding and getting to the root causes, getting to the understanding of the risk and the protective factor versus just using that initial oh, we have a youth drinking problem, we're going to do this. It's really more about, oh, we have a youth drinking problem. I wonder why, what's contributing to those problems, right? Why are youth engaging in risky behaviors? And figuring out those types of things so that you can work towards positive solutions that are going to, produce successful outcomes for us. If we tend to just jump to conclusion and just jump to thinking that we can replicate what we've done forever and ever ago, where you may have success the first 1 or 2 times, but at some point that's going to start to shift and it's not going to continue to work because you're dealing with different contributing factors, different populations, even perhaps across different community groups. And so the importance of really understanding what these are is so critical. So when we think about indicated prevention, risk, and protective factors, we are really talking about indicated prevention programs that are being used for individuals. Again, we've kind of talked about this, but indicated prevention programs are used for individuals who may or may not be misusing substances, but exhibit the risk factors. And again, we've talked about maybe it's school failure, maybe we've got some interpersonal social problems, delinquency, other antisocial behavior, psychological problems such as depression, anxiety, or suicidal ideation or behaviors that increase the chance of developing that substance misuse problem. And so what we know is youth that are already engaged in substance misuse and or negative behaviors like truancy, antisocial behavior, maybe they're a child of an individual with a diagnosis of a substance use disorder, they already are going to be more at risk, right? We just know that. And so again, thinking about the cross of selective and indicated is so strong, right? So we may have a group of individuals who have parents with substance use disorder. Their genetic predisposition already places them at a higher risk. They're already going to be closer to the target. Doesn't mean that they get there, they're just closer. And we know that. We know that as prevention professionals. So we have to think about that quite often and not forget about that target group. Now, when we think about these factors, I've talked a lot about the importance of checking assumptions, and it's still so critically important here as well. And when I say that, I mean, we can't just assume that we know what's placing people at risk. We also have to make sure that we've done our due diligence to understand what the scientific and research-based risk and protective factors are, because there's a plethora of them that already show support that if X is happening, Y could happen. So we don't have to make assumptions and think, well, oh, it's probably because of this. One of the most common, in my experience, your communities may be a little bit different, but when we have conversations with community partners, and we're talking about kind of, what's going on in our communities and really working to, to do some data sharing, but also work to maybe collect some qualitative data, hear from our partners as to what they're experiencing related to the problem. The number one assumption that I hear all the time about what is placing kids at risk for substance misuse and other behavioral problems is that they live in single parent homes. And that is the biggest miscommunication that probably we can say. There is no scientific evidence or research that supports children who live in a single parent household are at any type of increased risk for developing a substance use disorder than children who live in a 2-parent home. So that's a great example of how easy, it's so easy to say, well, it's a single parent home, so, we've got a parent that has to work, they're not home, so blah, 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 blah. Now, could there be some connection? Maybe, but we don't know that without having conversations. And so making that assumption is really unsafe, right? And so doing our work to understand what really are the risk and protective factors at place here, what really kind of is happening. And so when we think about risk and protective factors, specifically risk factors first, yes, Glenda, absolutely right. Children in a 2-person home can be at higher risk, just like children in a single parent home. So there are other risk factors to identify, right? Now, if the single parent home has a history of substance use, that's the risk factor, right? Not the single parent home. So it's just such a great reminder that we just really want to be careful. Thank you, Kristen. Just really great reminder to be careful of checking assumptions. We don't want to do more damage that's already out there. There's enough damage, right, that we're working to try and fix and repair the best way that we can. So when we're thinking about risk factors, it's nice to remember that there are contexts within risk factors. And so when we think about what that means, there are levels, I guess I like to call it that same thing as context. But in the risk factor, we have a couple of different areas to focus on. The first is really that biological risk factor. So again, like that genetic, so the predisposition, living with parents who are diagnosed with a substance use disorder, living with parents who have a history of mental illness, things like that. These are things we cannot change, right? So that's that example that they're there, they're present, you can't change them. It does not mean you will automatically have the same thing happen to you. It just means you are at a greater risk already because of that genetic predisposition, right? Psychological is another one. We kind of talked about that here. You can kind of see that on that slide, but maybe dealing with some depression, some anxiety. It's really, really common, especially among young people now. It's different. You know, our world is different. We spend a lot of times talking about this too, that there have been some pretty significant social factors in our world the last 5-7 years. And our young people are experiencing the results of those pretty big significant factors, right? So there's increase in depression, there's increase in anxiety among young people, maybe things that we're not so familiar with. And so it's important to just be mindful about those things, right? The other is family. So thinking about, again, just what could be going on at the family level, not so much like use, because that's more biological. So if a family member is using, I mean, it could connect here as well, but there might be some crossover with the biological. But you could think about family, like family involvement, parental monitoring. If you don't have any of that, you're at risk, right? Community is the same way. So if we have a community that has acceptance of substance misuse, or has norms favorable for substance misuse, doesn't have laws or policies in place that protect from that, it can be difficult. And so these types of risk factors are just giving you examples of how they can be preceding and are associated with a higher likelihood of those negative outcomes. Does not mean it's going to happen or will happen, just means that there is a greater risk for it to happen, and we need to be prepared for that. We also need to know how we connect to strategy, because the things I just listed, those 4 to 5 different contexts, they all have different strategies connected to the indicated strategies connected to them. So to say we've identified these 4 risk factors among this subgroup and we're going to do this one thing and hope, that's not enough, right? We need to have a comprehensive plan, a comprehensive approach, because we're not going to have enough, to address. We also talk about protective factors. A good reminder that we don't want to forget about the protective factors. We're comfortable talking about risk. We're comfortable talking about protective, but for some people, protective factors may be a little bit of a newer concept. For some, it may be something that they've been integrating forever. So each of us may be a little different, right? However, the protective factors are kind of like the opposite. These are those characteristics that are associated with that lower likelihood of experiencing negative outcomes that are going to reduce the impact that the risk factor may have. And so things like family involvement, it's kind of like the opposites that we talked about, right? Family involvement, family or community norms that are not favorable to substance use, things like that, high school attachment, things of that nature. What's important here to remember is that some risk factors are fixed, meaning that they don't change over time, right? So that like biological thing, you can't change that you have a predisposition or that you have family history of substance misuse. There's nothing we can do to change that. There are things we can do to help reduce the risk of you developing those types of substance use behaviors or mental health behavior disorder, things like that, but we can't change it. However, there are factors that are variable and can change over time. Things like income levels, peer groups, employment status, right? Those types of things can change, and they can certainly kind of help and move. But it's important to remember those different contexts as we work through these conversations. It's also good to know that because we do have those individual risk factors, again, going back to like genetic predisposition, we also have individual protective factors, positive self-image, social competence, self-control. Those are things that are proven to protect from those risk factors. So when we can work to understand what's contributing, we can work to impact how to create change and how to create protection around that. It's not so much that we can always change the risk factor, because sometimes we can't, but we certainly can change and influence the protective factor in our work as prevention professionals. So it's just a good reminder there as well. And then, like, as we were talking about those contexts, just some good reminders as we kind of move to our next conversation point here. With the conversation or with the contexts that we talked about, also thinking about it in relationships, communities, and society. And so relationships could certainly be, in terms of risk factor, could certainly be things of, again, parents who may be misusing substances or have a substance use disorder, parents who maybe suffer and struggle with mental health disorder, any type of like child abuse or maltreatment, inadequate supervision. Those are examples of those like relationship context risk factors. On the contrary, though, we also have relationship level protective factors like parental involvement, parental monitoring, things like that we kind of touched on. Same for community. So when you think about the holistic, kind of what is that community looking like in terms of risk factors? We may have neighborhood poverty, we may have neighborhood violence. And so those are just some quick, again, we could talk at length about all the type of things, just some things to be thinking about there. And so to counter that with protective, we do some indicated prevention work, maybe through after school programming, or maybe you partner with a faith-based entity. Again, just a total example here. I realize everyone may not have that exact structure. So speaks to the importance of understanding what we have in our communities through our resource assessment and resource capacity building. And then society or societal risk factors here. We talked a little bit about this, but those are going to be like those norms and laws favorable to substance use. Lack of economic opportunities and resources is a huge one, right? And so some protective things to work around that, maybe some policy work, policies that limit availability or access to the substance or to the product or things like that, right, is really what we're talking about here. And so again, just some quick examples. We again really could talk for a long time about what that could look like. We also can talk too much about it and not need and focus really more on what's specifically in our community is happening, right? So it's great to have the list and the information, but we want to do our due diligence to collect that data to the very best of our ability to make the connection to figure out, yes, it's happening, but we want to know why. And so really, really understanding that, because when we know why, we can identify the best indicated prevention strategy for that subgroup before we just make an assumption and just say everyone's going to get this program because it's the only one we have. Could be the only one that you have, right? So perhaps I think there's just, you want to just be careful about that. Some people may come and say, well, something's better than nothing. Not always. If it doesn't match at all, it not necessarily is better than nothing, right? And so really making sure we're doing our due diligence to understand what that looks like. All right. And so then we talk here about the effective implementation, of those strategies. And what do we mean exactly by how we effectively implement the indicated strategy, the indicated prevention strategy itself. So let's talk a little bit about that. All right, so we're going to do a little bit of chatting. You guys have been pretty participatory, so I hope you will continue to be, because it certainly is good for conversation. So we're going to take a few minutes and do this first one. So you can just do this in the chat if you'd like. Before we talk a little bit about selection and criteria, kind of get us thinking. So tell the group, tell all of us, how frequently are you implementing, indicated prevention strategies in your community? And you can just pop that into the chat. How frequently are you implementing indicated prevention strategies in your communities? Here we go. We've got some things coming in. Oh, we have a great example from James. I missed this one just a second ago, but as we were talking about assumptions, he talked about coming from a family with both parents. He was active in a Boy Scout in a large church, but also started using substances in 5th grade. So a perfect example, right? We can't make any assumptions that lend itself to thinking, well, that'll never happen because ABCD is in place. Thank you for sharing that, James. All right, so now we've got some things. So Waylin says weekly. Kayla says almost never. I'm gonna make this just a little bit bigger because I'm missing some things. There we go. Carla says rarely, very common for us too, Carla. Kayla, almost never. Weekly. Let's see, we've got weekly, not often, not often, not often. Programming and school suspension and juvenile, great. So working with your juvenile detention a few times a month, every 2 weeks in an alternative school environment, great. Prevention ed specialists use on an as needed case-by-case basis, tends to be pretty common, definitely. Not often. I work with, let's see, Glenda, I work with grand families created when a grandparent or other family member raises the child of a relative. Most of her children are parents with SUD. Yeah, that's a great example, Glenda. I like that term, grand families. I don't know that I've heard that. I like that. John says school year. Jessica says rarely. Yeah, pretty common, right? So thank y'all for sharing. This is great. And I do have a question. I think Alice was curious about slides. my understanding, Alice, they'll be posted on PTT's website, but I will refer that to Aaron and Shannon. 2 to 3 times a week with individual evidence-based programming and monthly through a youth group comprised of youth with lived experiences. That's great, Stephanie. So it's interesting because it's almost like some of you were doing it very, very frequently or not at all. And that is so common with indicated prevention. And, I think there's lots of reasons why. We talked a little bit about this already, that universal it's not easy in terms of the work. Goodness gracious, right? How many of us can relate? Universal prevention isn't easy. It's just broad. And so the reach can be a little bit easier because with selective and indicated, you have to identify that population, right? Everyone just doesn't get that. And so first and foremost, it's the identification of the target group that's going to take some time. To identify them, you have to be able to get access to them. That can be in a school setting. I mean, I don't know how many of you guys have barriers, but my goodness, have we had some barriers getting into a school? I mean, and to us, we're like, why wouldn't you want us in there? But to them, they have reasons, right? And so we have to sometimes navigate through these barriers before we can even get to the target population. This is also really important when we think about our assessment, because as the strong prevention professionals I know you all are, you just want to get in there and help and do your job, but not everybody wants us in there. And so we can't spend too much time planning without our partners. This is a great reminder. Stephanie says she feels like indicated is easier because other sources are identifying them, such as the youth. Yes. So oftentimes we have a system in place. Some of us have a system in place to get those identifications and get those referrals and referrals to us, but some don't, some don't have that. So it can be difficult. Certainly by case scenario for sure. And so what's important though, is that we have to be thinking ahead of time and working with our partners through our planning process so that we don't kind of miss something huge. We may sit around the table and put a whole comprehensive plan in place, but we've kind of left out the fact that we need to partner with a referral source, kind of like Stephanie is mentioning in the chat. If we don't have that in place, it can be really hard for us to reach that audience, to reach that group. We can't just walk into a school and say, point out the kids that you think are in the indicated prevention category. It doesn't really work like that, right? It also goes back to our topic and our conversation about making sure that people know who we are and who are aware of our information and who are aware of the things that we offer. Even in a court setting, I know, like Stephanie was mentioning, a great example, there's a court system or something like that in place. Even us, we've had to remind people, like, we're here, make sure that if you have a, ABC situation, you can refer them to us. And that comes so much with so many different things, transition of people in positions. We may have had someone who'd been there for 10 years who always referred to us, and she retired, good for her. She gets to move on. And then you get somebody brand new in who has to learn all those things. We have to meet those new people, right? They don't just know just because Janet did it forever that her replacement Kelly is going to do it forever. It doesn't work that way. So we have to continue to maintain those relationships to get those referrals, to get those resources. So great examples in terms of how frequently you're implementing. So for some, indicated prevention is very easy. It's very natural. It's very kind of works throughout. Some it's really difficult, right? Really difficult, which kind of lends ourselves to our next question that you'll see. And you can just put these in the chat as well. What common barriers have you identified when implementing indicated prevention strategies? What common barriers, or maybe to offset, since some of you were talking about it's pretty easy, like what are your successes? Like how have you moved through without the barriers? Share that as well. Let's see. John mentions no barriers in our school district, always welcome because of longevity in our community, 42 years, and our programs are proven, so keep going. That's great, John. So speaking really well to the community knows who the agency and organization is. They also know that they have effectiveness. It's a great, just a teeny, this is not so much related to the topic, but what a great reminder to make sure you're sharing your results and outcomes with your partner so that they know that you're doing effective work and you're not just in there and they have really no clue what's going on. So just great reminders to make sure your partners know how effective you are. Just put together a little fact sheet, a little one page, doesn't have to be anything comprehensive about your programs and your outcomes, can really help kind of reduce any barriers. I have one question from Leah. I'm going to come right back to that one. Leah, I see it. Just give me, I'll come right back to that one. Glenda talks about access. Families don't understand the need. Definitely prominent. Victoria talks about getting referral agencies to follow through with the actual referrals. Yes, great. I'm glad you agreed with that. Angelica talks about engagement from the community can be difficult and getting anticipation from the families. Yeah, it's hard, right? Like we see it all the time. Even if we're working in prevention, it's still connected, to substance misuse, and there's stigma, and they don't know what that means. And what does it mean if we have to come for services or receive services? They just don't understand, Cynthia talks about transportation, such a big barrier, Cynthia, right? Transportation for kids to get to where we offer indicated programs in the community. And we do our best, we do. I know you do too, Cynthia. You try to meet them where they are, but sometimes you got to have a building and a place to go to do the work, right? So it can be difficult to all get to that one place. Michelle talks about school administration can be a barrier. I've experienced that as well. My communities have 5 school districts. So we're large. And so like half of them are great. And the other half, we get some pushback, So we're still working on that. Lindsay talks about capacity can be a barrier. My goodness, yes, not enough staff to branch into more indicated programming. You're right, because it's different, right? It's different than universal and selective, and it requires specific attention and focus. Absolutely. Kayla talks about funding, lack of awareness and knowledge of the need, lack of access to data and the priority population. So many good points there, Kayla. Absolutely. Dana, it seems sometimes the parents and guardians are the biggest barriers. Absolutely. Because it's tough, right? Who are we, to bust into a family and say this and say that. And so again, it's that misperception that that's not what we're doing. We're not coming in to say anybody's a bad parent or parenting poorly. We're coming in to say that we all know that we all can use some help and we want to help. Let us help you. But it's misperceived often. So absolutely. Tracy talks about need to re-educate a referral entity due to a change in administration. Yep, need to educate to understand the benefits. Sometimes it just goes back to that, making people aware. Terry talks about challenges with maintaining program implementation and fidelity. Yep, student absences, such a big one, right? You're already in an alternative school where there's probably some behavior and some conduct issues, some truancy issues. You have to have the kids there to get the programming done. Absolutely. James talks about schools are under pressure to improve academic performance. Anything that takes away from desk time is unfavorable. Such a big one, right? So many conversations we have about that. And we get it, but what an opportunity to partner together and work together. Talks about concerns about the school or community image. Yep, community image is a big one. School doesn't want to be looked at as a problem school. Absolutely. Kayla talks about funding as in what we can and cannot do with it. Oh my goodness, this is my fight of the day, Kayla. Geared toward population level interventions and also sometimes just a lack of funding. Yeah, so sometimes we have the money, it's just so restricted, right? And we can only do so many things or so many specific things, and we have so many other things we want to be able to do. It can be really difficult. Again, fight of the day. James talks about one way to get better cooperation is to align with the school's PBIS program. So that's positive behavior interventions and support. So again, knowing who to partner with is so critically important. This is a great example, James. So critically important. Like, who do you partner with? Maybe it's not the principal. Maybe it's not the school counselors. Who knows, right? It's specific, and knowing who that is. Danielle, same thing. Funding limits what the grant funding allows. Funding, same with Dawn, it limits what you can and can't do. And we get it, right? I'm not saying anybody to do what they shouldn't be doing with their funding, but it's difficult when you have a need and you have some restrictions that you really can't deliver because of those funding limitations. It can be frustrating and really, really difficult. Rebecca talks about students who have broken the substance use policy get referred, but we have had struggles with people actually making their referral to the program. Yep, it's an alternative suspension, and some rather just suspend the students. We've worked through that a lot too. We've had some really great successes in schools really adapting that policy change, and some who have not. Yep, so difficult. So much influence from marketing technology, media influences generation are exposed too much at an early age. Yeah, John, it's different. Like, we're dealing with a different generation, right? We really, really are, which goes all the way back to what I was first talking about, the importance of being aware of that and being mindful and checking those assumptions, and what worked 5 years ago maybe doesn't work anymore. Great reminder. Sometimes staffing at the programs. One social worker at my facility, Rose, I feel you. My team is a team of 4 for 2 of the largest counties in South Carolina. It's tough, right? I mean, we can't reach everybody. And so it goes back to that importance of partnerships and collaboration. These are all such great examples. Thank you guys so much. I do want to go back to Leah's question they asked, what do you recommend as far as programming goes for indicated population? We actually get so many recommendations for the indicated population, but our programming is meant for more universal, broad, and the whole population, not for the 4 or 5 students that are indicated or caught in trouble at one moment. This is such a great question, Leah, and I'm glad you asked. So in terms of programming, I think it's going to have to depend on what you're identifying as the problem. And so for us, I'll just give you a quick example and then we'll kind of keep moving here, because we have a very similar problem too, right? We don't get a plethora of referrals, but we get them. And so we have to be responsive to them. It's certainly something we're working on building up, but that's just where we are right now. So for us, we tend to find ourselves working in the underage drinking and underage tobacco use problem type behavior. So engaging in that illegal activity and then coming to us for education-based programming tends to be pretty common. And so what we think about is, I knew that was going to happen. That's my dog. I'm so sorry. Excuse me. If you heard that crash, everybody's fine. He just likes to get into his toy bin and tip it completely over. So in terms of programming for indicated populations, there are several, right? There can be several. And so I think it's really about understanding what meets the most need for your community and your group at that time. What can you actually do with your funding structure? What do you have the ability to receive training in? What can you implement effectively as intended? And so really, really important there as well. And so you definitely are doing the right thing by not just implementing the universal program that you say you have, because you've identified that the group is really an indicated group. So that can just be difficult. Now, again, there's not harm in indicated populations being a part of the universal group. But if they're coming to us on a referral basis, we want to make sure that the program we give them is indicated, not universal, because it's different, right? But if they're a part of another group that you're going into a school and doing life skills, certainly they can participate and be included in that. Great questions there. All right, y'all had some really great barriers and some great examples and some great positive things too. So thank you for including both of them. Kayla talks about in Washington State Project, success is a widely used program in schools for indicate. Yes, I've heard about this as well. And oh, there she linked it. Awesome. Thank you so much, Kayla, for doing that. Leah says the biggest problem is the funding source and how limited it is because they want us to use universal for the indicate. And it is not always the best fit for the population. Yes. Yep. Again, fight of the day, right? If we know it's an indicated population, we can't just use universal. So you're doing the right thing by advocating, but I also know how hard it can be, right? Like I totally get it. So I think it just continues to be about conversations and identifying what works and doesn't work and advocating for what we know is right. But I hear you loud, so loud and clear that this can be such a difficult conversation to have. All right, let's look here. So now we're kind of talking about that programming, right? So how do we make selections? And so what we're thinking about looking at here is when we are doing kind of like a checklist almost in our minds, right? We're looking at programs, we've identified the problem, we've identified the population, kind of know what's contributing to it. Now it's time to pick program. And so this can also be tough because sometimes it doesn't always match, right? And so when we're looking at that, we want to make sure that the program or practice that we've identified as what we're going to implement is going to do these following things. It's going to address the priority substance misuse problem that we've identified, as well as the associated risk factors. We talked about a lot of those just a few minutes ago, and the associated protective factors. We also want to make sure that it's a good fit for that specific community. So I've got so many bad examples, and that's how we learn, right? Of thinking that I've identified this, I have a program that's been working here, and I'm just going to implement it in this community right across the street. And my goodness, the failure that we had still haunts me to this day, truly, that we just did poor program planning and poor implementation. And I'm okay to share that with you because nobody's perfect. We all make mistakes and we all learn from them. And so it's really important that we spend some time on selection criteria and making sure that we are addressing the following information. We want to do our very best to make sure that we are saying yes to these bullets, right? And so what we know is that it can be so easy for people to just want to select the program that's popular, that's well known, that, like I said, works in one community, so it's got to work here, or it's just that they're familiar, right? We've done this forever. We know, it might be a little outdated, but we've got it. We're trained in it. That really isn't the best reason to implement a program, right? It really needs to be more about it's focusing on our problem, it's integrating risk and protective factors, and it's a good fit for our target group, not because we've been doing it for the past 10 years and we all know how to do it pretty well. So if they don't meet these criteria, we want to think a little bit more about that, right? Now, these may not be the only criteria you look at. You may have other ones, and that's totally, totally great. This is just a quick example to be thinking about. What's really, really important to think about is the program or practice, effectively addressing the problem, right? And the associated risk and protective factors while being a good fit. Those are really critical. If you've identified one risk factor and the program you've selected has no connection to addressing that risk factor, the likelihood you're going to see successful outcomes is pretty limited. Julie talks about cost. Yes, sometimes we can't afford to do the program that works, and so we have to think differently on how we can get that program to maybe be active or maybe be a reality. But definitely an important indicator, as well as costs associated and training, right? You have to be trained, you have to be able to maintain that training. All those things kind of come into play. But at the very, very core, if we are not focusing on the problem, if our program is not focusing on the problem and the risk and protective factors or deemed to be a good fit, it would really be wise to take a step back and revisit that assessment data to identify what might be a better fit. What could we change? What could we look at? We definitely don't want to do any more harm to this indicated population group. And so selecting a program that doesn't meet any of these 4 bullets likely could do that. So we just want to be very cautious and very mindful about that. Right. And then how do we identify these individuals? We've talked a little bit about this. Maybe they're hard to reach, the target group, we know they're probably out there, but how do we get them? And so we know that individuals who are falling within the scope of indicated population can be referred to our prevention programs by parents, teachers, counselors, nurses, friends, youth workers, a judicial system, probably lots of, you can probably list some other examples too, of maybe experiences that you've had of referral sources. But as a reminder, the aim of this prevention programming through indicated prevention services is not just about that reduction in first time use, right? It's also about reducing the length of time, delaying the onset of the substance misuse, and reducing the severity of the substance misuse or any type of substance use, just if we're getting closer to that. It's not just about reducing the length of the first time. So we want to be mindful that this is a little bit more specific. It's indicated, right? That's why it's called that. It's much more indicated. It's much more specific than going to universal, perhaps. Nobody's more important, right? Nothing is better or worse. It just looks very different because it's supposed to look different. And then the next thing we want to talk a little bit about are the challenges. And we've talked about some of these already, but it's a great kind of start to a wind down of our webinar together today. And so when we think about challenges of indicated strategies, the first thing we note is that these indicated strategies do require a precise assessment of an individual's personal risk and level of related behavioral problems. And so that means we have to have the information. We can't make assumptions. We can't just think we know. We actually have to have the precise information to identify these people as indicated. We may not do the assessment, but we still have to have the information, right? We also note that the programs are frequently extensive. They are much more intensive than maybe a one-time universal presentation to all 7th grade students. Not less important, just much more extensive and intensive. They generally are going to operate for longer periods of time, have more contact with the individuals, require participation of those individuals. So we talked a little bit, that was one of the barriers. You're in there, you're in the group, you're with them, but they don't participate. So it takes longer because they have to, right? You can't just walk out and say, well, I tried. They have to participate at some point. And then we know that programs require highly skilled staff who have gone through the training and have other skills. Again, so important that we don't just walk in saying, well, I'm in prevention, so I know what I'm doing. You have to be trained in the program so that you can make sure you're maintaining it as you're supposed to. And so when we think about that, it's wise to be mindful and to take assessment of where we're at in our ability to implement this as intended. And so we talk about how we maintain that fidelity. So maintaining fidelity, meaning we're making sure that we are implementing the program as it was intended to be implemented, meaning number of sessions, with the appropriate audience, with the appropriate materials, with a trained facilitator. Those are just some quick examples, but also making sure that we're being mindful about any adaptation that we have to make. So any type of change that we may have to make to meet local circumstances, we're being mindful about that. A great reminder is don't make any adaptations without having a conversation with the program creator, at least who developed that program, who oversees it, and having share with them kind of what's going on and what you may need to change and why. So those are just some things to think about when you're working through indicated prevention as well, that you're maintaining that fidelity and adaptation pretty balanced. All right, so with that, I think we've got a few moments for questions before I think Chris is going to join us and close us out. So I just want to, before I pass to Chris, if anybody have any questions that you want to put in the chat or anything like that before I end my chat. Give that maybe a minute. Y'all have been really active throughout, so you may not have any questions at the end, which is nice. We've been able to answer them most in real time. I think we've got about 5 minutes, so I don't. Oh, there I see something. Megan says, "Can you share your contact information?" Yeah, Megan, I'm happy to do that. I will send you a message. Thank you, Sandra. I appreciate that. Okay, so I think that may be it. So Chris, I am going to mute myself, but I'm going to advance the slides for you.
I'll go ahead and share it from mine because I added in a couple more things just to respond to what folks were talking about today. So
perfect. I'm going to go ahead and stop share.
I'll go ahead and here we go. All right. Well, thank you so much, Ashley, for presenting this fantastic information. Such useful and important points that you made about indicated prevention that we don't always talk about. And we've got the requisite cat that comes just as along the screen. All right, well, I want to make sure to let you all know about some upcoming events that we have. First, we have on September 20th, the importance of advocacy for prevention, what it is, and tips for conducting it. So with this, we're looking at the difference between advocacy and lobbying. Many questions have come up about this, and we want to make sure you all are clear about the difference and what you really can be doing in terms of advocacy. On October 5th, we have What Makes Them Stay, help write the playbook for prevention workforce retention. We know that's been an issue for many folks in the prevention field, so come get some tips and ideas and help contribute to that discussion. Few things coming up. To save the dates, on October 12th, we don't have the registration open yet, but it will be soon, on prevention with immigrant, refugee, and asylum seeking communities. We will also be opening up soon a training on coalition basics on October 26th. We have the virtual SAPS is going to be held again in November. This is just for Region 5 preventionists. So those are the states listed right there is who's in Region 5 in case you wonder if you are in Region 5. So Ashley had mentioned risk factors and protective factors quite a bit. And if that's new to you, that information, or you're just feeling like, gosh, I need to brush up in those areas, we will be holding 2 trainings on protective factors and risk factors. It'll be December 5th and January 9th. I'll be leading those trainings, so I look forward to doing that. But it's so important, as Ashley was talking about, that we really truly understand what those risk and protective factors are, because that's going to be the key information we need to be able to identify what strategies we want to be implementing and where we need to be focusing our attention. So if you're feeling the need to brush up on that, or that's new to you, please plan on joining us for those sessions. I want to also make sure everybody knows about our prevention portal on our website. If you go to the gray area of our website, kind of that gray band, you can click on Prevention Learning Portal, and you will see on that Prevention Learning Portal, there is a page on the spectrum of mental, emotional, and behavioral interventions. So you'll find more information about that if you're looking for that. We will also be posting this series of webinars that Ashley has done for us on that page. So you'll be able to find that you'll be able to easily find that there. And what happens when you click on that page, it will look like this. Every page on the portal has a what is it, learn about it, and take action. So we took all the information we could find out there, distilled it down to some real key pieces of information on each topic within the portal. So check it out if you haven't already. I encourage you to like and follow us. If you're a LinkedIn person, we've got a LinkedIn page. If you're a Facebook person, please join us there on Facebook. This is where we put up real pertinent, up-to-date information. So as we get information each day, that's where we go to post it. So hopefully you can join us on one of those pages if you are a social media kind of person. And last but not least, please, please, please complete our evaluation form. This is key for us to send information back to our funders, but also it's really important for us to know what's working well and what's not working well in these trainings. As I mentioned, if you're on our training yesterday, just to let you know, I read through every single one of your comments. So please know that it's not that you're typing stuff in and it goes nowhere. It does get read. We forward the information on to facilitators and trainers as they request it, and we take it to heart. So please take time to do that. And with that, any last questions? Or Ashley, did you have anything more to add?
Nothing really, just a thank you to PTTC, obviously, for having me. It was a really fun webinar. I liked the ability to break this into 3 because they both really, all 3 chunks really warrant their own conversation. So it was a really nice setup. So just thank you to Chris and Aaron and Shannon for having me, and for all the participants for being so participatory and involved. It was so nice to meet all of you and hear the different perspectives that we all bring. And I just wish you all continued success in your work and keep doing all the great things you keep doing. Thank you for having me.
Thank you. Everyone have a great rest of your day. Bye-bye.